Here is a number that should stop you cold. Studies suggest that somewhere between 10 and 20% of all operations performed in the United States every single year may be completely unnecessary. For spine surgery alone, more than half of all lumbar procedures have been flagged in the medical literature as operations that could not be adequately justified. We are talking about millions of Americans going under general anesthesia, having their bodies cut open, spending weeks in recovery, and living with permanent scar tissue inside them, for operations they may never have needed in the first place. I am Dr. Arthur Vance, and if you have ever been handed a surgical referral, or if you are living with a condition where someone has told you surgery is the next step, this video is for you. Let me start with the most important principle in all of surgery. It is something experienced surgeons understand deeply, but rarely say directly to a patient sitting across from them. The best operation is the one that never had to happen. That is not cowardice. That is not a doctor being overly cautious. That is hard-earned medical wisdom built from decades of watching what happens after the scalpel touches skin. The moment you have surgery, something permanent happens inside your body. Scar tissue forms, dense fibrous material your body lays down to seal any wound. That scar tissue does not disappear over time. It remodels the mechanics of the surrounding structures. It can compress neighboring nerves and blood vessels. It restricts movement. It changes the way your body distributes load and pressure, and it is there for the rest of your life. This is why every surgeon asking the right questions should be asking one thing before scheduling any procedure. Have we truly and completely exhausted every non-surgical option? Because once you go under the knife, that question has no more answers. Let me walk you through 5 operations that, in my experience, are performed far too often without sufficient justification, and what should be happening instead. The first is spinal disc herniation surgery. Here is how this typically goes. You develop low back pain, you get an MRI, the report mentions a herniation or disc protrusion, and within a few days a surgeon is telling you that you need an operation. What nobody tells you at that appointment is this: if you took 100 completely healthy adults with no back pain whatsoever, no complaints at all, and put them all through an MRI of their lumbar spine, roughly 50 of them would show a herniation or disc protrusion on the scan. Half the population walks around with findings that look exactly like yours on imaging and feels nothing, which means the image on the scan is not your diagnosis. The image is a finding. The actual diagnosis requires that a patient is suffering in a way that directly matches that finding, and that all other causes have been reasonably ruled out. And even when someone genuinely has painful sciatica, nerve pain radiating down the leg from a compressed disc, surgery is almost never the right first answer. There is one situation where it is a genuine emergency. When compression of the nerve bundle at the base of the spinal cord becomes so severe that a person develops progressive weakness in the legs, loss of bladder or bowel control, or numbness in the groin and inner thighs, that is called Cauda equina syndrome, and it requires urgent surgery. But this is rare. The overwhelming majority of herniation cases involve chronic low back pain and intermittent sciatica, and these respond well to conservative treatment when that treatment actually addresses the mechanical cause of the problem rather than just managing the pain. Here is the physiology that explains why surgery alone so often fails in the long term. Your spine is a column of bones separated by discs. Think of each disc as a firm, gel-filled pad that distributes pressure evenly between the bones above and below it. When the loading across your spine is balanced and symmetric, the disc stays centered and does its job. But when your pelvis is rotated out of alignment, when the deep stabilizing muscles of your lower back are in chronic spasm, when old injuries have shifted the mechanical balance of your skeleton, the pressure on the disc becomes uneven. The disc gets pushed harder on one side and bulges out the other. That bulge is the herniation. Now here is the critical question. If you surgically remove that bulge, but do nothing about the asymmetric loading pattern that created it in the first place, what happens? Your body still needs a buffer between those vertebrae under uneven pressure, so it builds another one. Within 2 or 3 years, you often have a new herniation at the level above or below the one that was operated on. This is not bad luck, and it is not a surgical complication. It is a completely predictable biomechanical outcome of treating the result rather than the cause. The research on this is very clear. Studies comparing surgical and conservative treatment for lumbar disc herniation consistently show that surgery produces faster pain relief at around 6 weeks. But at 1 year and at 2 years, the outcomes between the surgical group and the conservative group are statistically comparable. There is no significant difference in pain levels or function by the 2-year mark. And the reoperation rate after disc surgery runs between 8 and 12%, meaning roughly 1 in 10 patients ends up back on the operating table. So before you agree to spinal surgery, work through a genuine full course of conservative treatment with a specialist who understands spinal biomechanics, not just pain management, but the actual mechanical cause of your imbalance. Only if you develop progressive neurological symptoms, worsening leg weakness, or changes in bladder and bowel function that are not responding to conservative care does the surgical conversation become genuinely urgent. The second operation that is performed far too often without sufficient justification is hemorrhoid surgery. Hemorrhoids are swollen veins in the rectum and lower anal canal, essentially varicose veins of the lower digestive tract, and they are extremely common, especially in adults over 50. Surgeons are often quick to recommend an operation, particularly when there is visible bleeding. And yes, surgery does work. Studies confirm that surgical treatment achieves higher rates of complete symptom resolution compared to conservative measures. But here is what those studies typically do not address, and what I want you to think carefully about before you agree to go under general anesthesia for this. In many cases of hemorrhoidal disease, the mechanical contributors to the problem have never been properly evaluated. One of the most important and most overlooked is a condition called visceroptosis, the descent of the abdominal organs downward from their normal anatomical positions. When the intestines, the stomach, and other abdominal organs shift downward and press into the pelvis, they put direct pressure on the network of veins around the lower bowel. Blood cannot drain upward properly against that pressure. It stagnates. The veins engorge and eventually rupture. A second overlooked contributor is an old tailbone injury. When the tailbone, the coccyx, has been traumatized, it can block the subtle rhythmic motion of the sacrum, the large triangular bone at the base of your spine. That sacral movement normally assists venous drainage from the pelvis. Block it, and venous congestion builds. These mechanical contributors can be assessed and addressed before any surgical decision is made. And when they are addressed properly, a meaningful number of patients who were scheduled for surgery never need it. In cases where surgery is ultimately necessary, correcting these upstream mechanical factors beforehand significantly improves the surgical outcome and reduces the rate of recurrence afterward. This is not instead of surgery. It is what should happen before surgery. The third operation is surgical repair of diastasis recti, the separation of the two vertical bands of abdominal muscle that run down the center of the belly along the connective tissue seam between them. This condition appears most often in women after pregnancy and childbirth. The abdomen visibly domes or cones outward when the person rises from lying flat. When the separation measures 6, 7, or 8 centimeters, surgeons frequently recommend stitching the edges back together surgically. Here is what I have watched happen repeatedly in clinical practice. Women who are told they need surgery begin a supervised program of corrective rehabilitation exercises, not crunches, which actually make the separation worse, but deep core stabilization work targeting the innermost abdominal muscle and the pelvic floor. Within several weeks of proper, well-supervised exercise, a separation that measured 7 centimeters is down to 3. No anesthesia. No scalpel, no scar tissue, no 6 weeks of post-operative restrictions. The surgical indication simply disappears with the right exercise program. The reason this works comes down to basic physiology. Muscle is living tissue. It responds to the right mechanical stimulus. When the correct loading pattern and pressure management are applied consistently, the connective tissue between the muscles remodels and the muscle bands migrate back toward the midline. This is exercise physiology, not wishful thinking. And consider what surgery cannot do. A surgeon can bring the edges closer together with stitches, but that does not restore muscle strength. It does not rebuild the connection between the nervous system and the muscle fibers. It does not restore coordination. If the muscles remain weak after the repair, the separation can come back. The structure is physically closed, but the function is not restored. So if you have been told your diastasis is large enough to require surgery, pause before you agree. Get a referral to a pelvic floor physiotherapist with specific diastasis training. Follow the program honestly for 2 to 3 months and measure the gap again. You may find the surgery is simply no longer necessary. The fourth operation is vascular surgery for varicose veins, and this one connects directly to what we just discussed about hemorrhoids, because the core mechanism driving both conditions is often the same. Your leg veins are a low-pressure return system. Blood climbs back up toward the heart against gravity, pushed along by the calf muscles and a series of one-way valves inside the veins. When the valves work properly and the muscles are active, blood flows upward efficiently. But when the abdominal organs have descended and are pressing down on the major venous vessels of the pelvis, again, that condition called visceroptosis, it creates pressure above the leg veins that prevents blood from draining upward normally. The veins in the legs begin to distend under that increased pressure. The valve leaflets, which are delicate structures designed for low-pressure operation, start to fail. Blood pools in the legs, the vein walls stretch. First you see the fine red and purple surface capillaries. Then ropey, bulging varicose veins appear on the surface. The process takes years, sometimes decades. Modern vascular surgery offers laser ablation, injection therapy that scars veins closed, and mechanical stripping. All of these procedures produce good cosmetic results. The bulging disappears and the leg looks better. But if the organ descent driving the venous pressure has not been corrected, the same pressure gradient will build new varicose veins within 2 to 3 years. I hear this from patients regularly. They tell me they have already had the procedure done twice and it keeps coming back. That is not a surgical failure in the technical sense. That is a failure to address the underlying cause. At early stages, spider veins, mild surface dilation, no skin changes, addressing the mechanical contributors, correcting organ position, strengthening the supporting musculature, and addressing nutritional deficiencies like vitamin D that weaken vascular walls can actually stop the progression entirely. At later stages where surgery is clearly warranted, restoring pelvic mechanics first means the surgical result lasts. One well-prepared procedure that holds, rather than the same procedure repeated every few years. The fifth operation is surgical repair of pelvic organ prolapse, the surgical lifting and anchoring of a descended uterus, bladder, or rectum. This is a significant procedure, and most women who reach the point where it is recommended have been aware of a problem for years, but did not address it early enough. The mechanism is a two-sided failure. From above, the abdominal organs have descended and pressed downward into the pelvis. From below, the muscles of the pelvic floor, the group of muscles forming the base of the pelvis, have been weakened, often by childbirth, sometimes by chronic straining from constipation or by inherited connective tissue weakness. The ligaments that suspend the pelvic organs lose their strength. The uterus, the back wall of the bladder, the front wall of the rectum, they begin to slide slowly downward toward the vaginal opening over months and years. That gradual nature of the process is simultaneously the greatest danger and the greatest opportunity. The danger is that people adapt to slow change. You stop noticing what has shifted. Your symptoms feel normal because they have been there so long. The opportunity is that at early and moderate stages, this condition responds very well to conservative intervention. Pelvic floor physiotherapy, targeted rehabilitation of the abdominal wall, and structural correction of organ position are all evidence-based approaches that can prevent progression significantly. The window where conservative management works is real and it is meaningful, but it is only open for a limited time. A first or second degree prolapse treated seriously and consistently can often be managed without surgery for life. A third degree prolapse that has been ignored for years is a surgical case with no remaining conservative option. The intervention itself does not change. What changes is the stage at which you decide to act, and that changes everything about the outcome. Here is what age means for all 5 of these conditions. After 50, the connective tissue changes that drive every one of them. Disc degeneration, weakening of venous walls, loosening of ligaments, thinning of the fascia, accelerate noticeably. In women, the decline in estrogen after menopause directly contributes to pelvic floor weakening and increased herniation risk. In men, core muscle mass decreases and lumbar loading patterns shift in ways that increase disc stress. These are not theoretical concerns. They are changes that show up on examination every week in any clinic seeing adults over 50, which means that for everyone in this age group, the urgency of addressing these problems conservatively and early is higher than it was at 35, not lower. Let me bring this together with the practical guidance I would give you if you were sitting across from me in my office. For disc herniation, do not consent to surgery because of an MRI finding alone. Surgery becomes genuinely justified only when you have progressive neurological symptoms, worsening leg weakness, or loss of bladder or bowel control that have not responded to a genuine and complete course of conservative biomechanical treatment. A few sessions of generic physical therapy does not qualify as a complete conservative workup. Months of proper treatment targeting the actual mechanical cause of the imbalance does. For hemorrhoids, before agreeing to an operation, insist that the mechanical contributors be evaluated. Is there organ descent pressing on the pelvic veins? Is sacral mobility restricted? Has the tailbone been assessed? These are not exotic requests. They are basic diagnostic steps that should precede any surgical referral. For diastasis recti, a gap measured on imaging is not an automatic surgical indication. Work with a qualified pelvic floor physiotherapist for 2 to 3 months, following the correct exercise program consistently, and measure the gap again before making any decision. For varicose veins, if you are still in the early stages with surface changes only and no significant skin damage, address the mechanical and nutritional contributors first. If surgery becomes necessary later, do it on a body where the upstream cause has already been corrected, so the procedure holds. For pelvic organ prolapse, if your doctor identifies early prolapse, that is not a moment to monitor and wait. That is the moment to act aggressively and conservatively, immediately. Pelvic floor therapy and structural rehabilitation at stage 1 can realistically keep you off the operating table for life. Waiting until stage 3 removes that option permanently. In every one of these 5 situations, the key word is first. First, find the actual mechanical cause. First, work through the conservative options completely and honestly. First, restore the structural foundation of the affected system. Then, if surgery is truly the only remaining path, go into it prepared, with corrected mechanics, restored tissue quality, and eliminated upstream drivers. Then the surgery is done once, and it holds. The medical evidence on this is consistent. Long-term outcomes for conservative and surgical management of many of these conditions converge over time. Surgery gets you there faster in some cases, but the body, given the right conditions and the right treatment, often gets there too, without anesthesia, without scar tissue, without recovery time, and without the risk of being one of the 10 to 20% who undergo a procedure that was never truly necessary. Give your body the chance to show you what it can do before you agree to let someone cut it open. The window where that chance exists is real. Use it while it is still open.